So the topic is candidiasis. It is caused by candida, which is a small ovoid yeast, which is around 4 to 6 micrometers in size. It reproduces by budding, and it exists in three forms: blastospores, pseudohyphae, and hyphae. It grows readily on simple medium like sabbal or dextrose agar. And there are various species of candida. To identify the species of candida, we have to do either biochemical testing, which is currently being done with automated devices, or with a special agar like chrome agar. Like on chrome agar, different species of candida produce different colors. So based on that, we can identify the species of it. There are around 200 species of candida, but in humans, only a few species of candida are pathogenic, like Candida albicans, Candida guillemondi, cruzi, parapsilosis, tropicalis, kefir, lusitaniae, dubliniensis, glabrata, and Candida auris. Candida glabrata is also called as Neckasiomyces glabratus. These candida, they're ubiquitous in nature. It means they're found everywhere. And in humans, they inhibit the GIT, female genital tract, and the skin. So there are various peculiarities of each of these species. Like most of the infections of Candida albicans and Candida glabrata, the source of infection of these is endogenous. And Candida parapsilosis causes infection in neonates and elderly. And it is associated with poor hand hygiene and associated with total parental nutrition. Candida tropicalis is the most important species found in India and Pakistan, and it is present on the skin, hair, and nails. Okay. And Candida cruzi causes infections in people with hematological malignancies and stem cell transplant recipients. And Candida auris is a multi-drug resistant, multi-antifungal resistant Candida, and it's related to health. It is healthcare related organism, and it causes healthcare related outbreaks. So if a patient is infected with Candida auris, the mortality will be high because it is resistant to various antifungals. So if a patient is infected with Candida auris, we have to isolate the patient in a single room, disinfect the room with based products, take precautions like wearing masks and gown. So initially, most of the Candida was Candida albicans before the introduction of antifungal drugs. But now with the introduction of antifungal agents, now almost half of the Candidemia cases are caused by non-albicans species. So in countries where advanced medical care is not so common, in such places we find mucocutaneous infections like thrush more commonly than nape organ infections. But in countries where there is advanced care, like where they're using broad spectrum antibiotics and giving aggressive treatment for cancer with chemotherapy and all, and using immunosuppressive agents to sustain organ transplants, in such countries, deep organ candidiasis is increasing. And in developed countries, Candida is among one of the most common nosocomial pathogens. So this Candida can enter blood, and from there it can lead to hematogenous dissemination and hematogenous seeding of various organs, and that's called as invasive candidiasis, and that's the most serious form of Candida infection. So this blastospore stage converts to pseudohyphal and hyphal stage, and that leads to penetration of the tissue, and then it leads to infection. Adherence to epithelial and endothelial cells is the first step in infection, and adhesins help in this, and that's why adhesins are important in the pathogenesis of Candida. And Candida also produces a toxin called candidialysin, and it forms biofilms, which is important in the pathogenesis. So against this, our innate immunity is the most important defense. And among innate immunity, neutrophil is the most important component of this defense. Along with neutrophils, macrophages, STAT1, Dectin-1, Card9 pathway, Th1 and Th17 lymphocytes also contribute to innate ones. But neutrophil is the most important component of this defense, and that is why in neutropenic patients, candidiasis is more common. So any condition which leads to immune suppression or breach in the skin or mucosal barrier can lead to hematogenously disseminated candidiasis. So all these conditions predispose to hematogenously disseminated candidiasis, like broad spectrum antibiotics, parenteral glucocorticoids, ICU stay, central venous catheter, IV catheters, urinary catheters, respirators. Patients with neutropenia, patients with HIV with low CD4 T cell counts, patients who are being given cytotoxic chemotherapy for cancer, immunosuppression for organ transplants, patients with diabetes, chronic renal diseases, chronic renal disease on dialysis, and liver disease patients, patients who are on total parenteral nutrition, elderly and neonates, low birth weight neonates, and any surgery which leads to surgery or severe burns which leads to breach in the skin or mucosal barrier. All these are they're predisposed to hematogenously disseminated candidiasis. So this candidiasis can either be a superficial infection in the form of mucocutaneous candidiasis or a deeply invasive candidiasis. So firstly, mucocutaneous candidiasis. Mucocutaneous candidiasis, there are various conditions like oropharyngeal candidiasis, esophageal candidiasis, vaginal candidiasis, and paronychia, onychomycosis, various other things. So in thrush, this is thrush, which is this is oropharyngeal candidiasis. So this we can see white and then painless patches in the mouth, tongue, or esophagus, and they can also occur at the points of contact with dentures. It's more commonly a non-specific manifestation of any severe illness, but if we find it in young, healthy, otherwise healthy patients, we have to rule out any underlying immunosuppression and test for HIV. Vulvovaginal candidiasis is characterized by pruritus, pain, and vaginal discharge, which is usually thin. But in severe cases, it may be characterized by whitish curds. In deficiency of dectin-1, there is improper functioning of card9 pathway, which, as I said, is important in the pathogenesis. It is important in the defense against the pathogenesis of Candida. So, whenever there is deficiency of dectin-1, because of improper functioning of card9 pathway, there is recurrent vaginal infection. Paronychia is painful swelling in the nail skin interface. Onychomycosis is nail infection. Intertrigo is infection of the skin folds. Balanitis is infection of the glans penis. Erosio interdigitalis blastomycetica is infection between the digits, and there may be folliculitis in the area of beard. In perianal candidiasis, there will be pruritus, erythema, and pustule formation around the anus, and a similar thing in infants is called diaper rash. And in disseminated cutaneous candidiasis, there is widespread macronodular lesions will be seen over the trunk and extremities, and it's more common in infants and more common in patients with neutropenia, but it can also occur without neutropenia. So these widespread macronodular lesions, whenever we see this, there is a high probability of hematogenous dissemination of Candida. Chronic mucocutaneous candidiasis is infection of skin, mucosa, hair, or nails, which persists despite intermittent therapy. And the onset is usually in infancy or the first 2 decades of life. This can be either a mild form or a severe form. In the mild form, it will be restricted usually to a specific area of the skin or nail, like that. But in the severe form, it may be disfiguring with exophytic outgrowths, and that's called as Candida granuloma. In this condition, the neutrophil function is usually intact. Because of that, with chronic mucocutaneous candidiasis, hematogenous dissemination of Candida is usually rare. So this is onychomycosis, fungal nail infection. This is paronychia with infection in the skin nail interface. This is infection of the skin folds, intertrigo. This is erosio interdigitalis blastomycetica, infection between the digits. This is Candida granuloma. This is the severe form of exophytic. This is the severe form of this chronic mucocutaneous candidiasis, Candida granuloma. And these are the macronodular lesions seen in hematogenously disseminated cutaneous candidiasis. With chronic mucocutaneous candidiasis, half of them can be having this APE-CED syndrome. This is autoimmune polyendocrinopathy, candidiasis, ectodermal dystrophy. This occurs because of mutation in autoimmune regulator gene. In this syndrome, the patient may have various endocrine abnormalities in the form of adrenal insufficiency, Graves' disease, autoimmune thyroiditis, hypoparathyroidism, chronic active hepatitis, malabsorption, juvenile onset pernicious anemia, alopecia, primary hypogonadism, and rarely dental enamel dysplasia, vitiligo, pitted nail dystrophy, calcification of nipple, etc. So this was all about mucocutaneous candidiasis. Now we'll see invasive candidiasis. So as I said, invasive candidiasis first start with candidemia. That is the hematogenous C. There is very hematogenous dissemination of candida to various organs. And in invasive candidiasis, like any organ can be affected, like muscle, joint, bone, anything. But the most commonly infected organ is brain, chorioretina, heart, and kidneys. Liver and spleen are less commonly affected, but they're more commonly affected in neutropenic patients. And it can, through the blood, when it spreads to skin, it will produce classic macronodular lesions, as I said, with the disseminated cutaneous candidiasis. And when the skin is involved, the underlying muscle will also be involved. Whenever we see chorioretinal or skin involvement, there is a high probability of hematogeneously disseminated candidiasis. Now, with ocular involvement of invasive candidiasis, it can produce endophthalmitis, candida endophthalmitis, and that can lead to intravitreal scarring, and that may lead to permanent blindness. So, for every patient with candidemia, whether or not the patient has ocular manifestations, we have to go for an ocular examination to rule out this candida endophthalmitis. And in case of ocular involvement, partial vitrectomy or intraocular injections of antifungal agents are helpful. So whenever we this invasive candidiasis, it's not just whenever any deep organ is infected, it is not sure that it has come from the blood, because if there's any superficial esophageal erosion, the candida can penetrate from the superficial erosion to the deeper esophageal layers and cause a deep esophageal infection. And it may spread from the skin to the joint or a deep wound. It may spread from the urinary tract to the kidney. It may spread, and candida are present in the GIT. So if there is any perforation of GIT, it can go out from the GIT into the peritoneum and cause infect the peritoneum and intra-abdominal organs. And it can go from the GIT in a retrograde way into the biliary duct and then go to the gallbladder and infect the gallbladder. So it may or may not be due to a hematogenous C. So to diagnose invasive candidiasis, there are no specific signs and symptoms. The diagnosis is through culture and microscopic examination of sterile body specimens. But we have to suspect invasive candidiasis if we have a patient with sepsis and the patient is having risk factors for candidiasis and the patient is immunocompromised and we're giving empirical broad spectrum antibiotics, and still if the patient is not responding, then we have to suspect invasive candidiasis. And any patient with signs of infection who is not responding to broad spectrum antibiotics, we have to suspect fungal infection. So for the diagnosis, we can either use microscopy. Under microscopy, we can see the pseudohyphae or hyphae, and on culture, we can find it out on culture. We can also identify the species and do an antifungal susceptibility testing, molecular assays like PCR, and beta glucan test. This beta glucan test has a high negative predictive value. It means if it is negative, then mostly it won't be candida, because this beta glucan is a part of the cell wall of candida. Nowadays, for the identification of species, we are using Marley-Top technique, that is matrix-assisted laser desorption ionization time of flight. In the diagnosis, if we find candida in sputum, it is almost never indicative of an underlying pulmonary candidiasis, and so we mostly don't have to treat it if there are no signs and symptoms. And if the patient is having an IV catheter, and in such patient if we have candida in blood, we cannot distinguish it from seeding. See, the candida can grow with the IV catheter and then it can lead to seeding of blood from the growth. Or else it could be it could be candidiasis. But there is no test to distinguish that colonization and hematogenous dissemination. So whenever we find candida in blood, we have to treat it. If the patient is on a bladder catheter, if the patient is on a urinary catheter and if we find candida in urine in such a patient, then we cannot distinguish whether we will not know if that is colonization or infection. But if the patient is ill, we have to treat it. And for that, if it is Candida albicans, we can use oral fluconazole. And if it is a non-albicans species, we can go for echinocandins, although they're poorly excreted in urine. So for the treatment of mucocutaneous candidiasis, if it is cutaneous, then topical 1% clotrimazole twice daily. While for the vulvovaginal candidiasis, fluconazole 150 mg single dose or 1% clotrimazole cream for 7 to 14 days. Oropharyngeal candidiasis, clotrimazole 10 mg troches 5 times per day for 2 weeks or fluconazole tablet 200 mg on first day followed by 100 mg per day for 2 weeks. For the esophageal candidiasis, fluconazole 200 mg on first day followed by 100 mg per day for minimum of 3 weeks. So for hematogenously disseminated candidiasis or suspected hematogenously disseminated candidiasis, we have to treat. If it is Candida albicans, it is sensitive to fluconazole, so we can give fluconazole. But for other non-albican species, they're less sensitive to fluconazole, but more sensitive to polyenes and echinocandins. So initially, since we don't know the species initially, we will start with broad spectrum agents like echinocandins and polyenes. And once we identify the species, we can change accordingly. And if the patient is having any indwelling IV catheter, we have to either remove it or replace it. And if the patient has any infected prosthetic material like an artificial joint, then we have to remove the infected material and give antifungal based on the sensitivity of the species. In Candida endocarditis, we have to remove the infected valve and give long-term antifungal treatment. Candida endophthalmitis, as I said, we can do partial vitrectomy. It can preserve the site by debulking the infection. For hepatosplenic candidiasis, we have to give echinocandin for 2 weeks. After that, shift to triazole. So these are the drugs used for the treatment of disseminated candidiasis. Amphotericin B deoxyfolate is 0.5 to 1 mg per kg per day. Liposomal amphotericin B is 3 to 5 mg per kg per day. Azoles, fluconazole, voriconazole are 400 mg per day. Posaconazole, giving orally, it is 200 mg TID. If giving IV, 300 mg per day. Echinocandins, caspofungin is 50 mg per day. Anidilafungin, micafungin, 100 mg per day. Azoles are both IV and oral. So mortality from candidemia and disseminated candidiasis is 30%. Prophylaxis against candidiasis is given for stem cell transplant recipients and high-risk liver transplant recipients. So for that we give fluconazole 400 mg per day. For neutropenia, we can give for patients with neutropenia, we can give either fluconazole, posaconazole, caspofungin, liposomal amphotericin B or itraconazole suspension. Some surgical patients who are at very high risk, prophylaxis is given, but it's not given for all patients. And in case of HIV, prophylaxis is not recommended unless there are frequent recurrences of candidiasis. Thank you.